Hello, dear friends, once again. We have met, and this time we will be talking about what I believe is a very important clinical topic that doesn't just stay within the confines of eye diseases, but has a very broad scope. This is the connection between neurological diseases and the ophthalmological diseases. Well, as you know, the brain and the eyes are essentially a unified whole. In general, the eyes are like a part of the brain that is brought out to the periphery during the process of embryogenesis. And in this way, we essentially bring our brain to the outside, to the periphery. And in this way, we essentially bring our brain to the outside. This is the place where the brain comes out. We bring our brain to the outside. This is the place where the brain comes out, and we can, so to speak, see what's happening around us. Then convert the energy of light into electrical energy and perceive it accordingly by the higher centers of our nervous system. What happens around us? But it's not just about what happens around us. These are all the reactions of the eyes. Everything, starting from the pupils to the movement of the eyes. All of this is also regulated by the nervous system. Depending on the information that is perceived with the corresponding cells in the eyes and along the axons, they are then directed along a complex nerve pathway in the visual cortex. One of the classic syndromes that are associated with nervous system diseases have a pronounced eye manifestation, the so-called Horner's syndrome. We're going to start talking about all of these, about some of them in order. Yes, here I want to say that we won't be able to cover everything again, because in reality, there are a lot of diseases that have eye manifestations, and very often, based on what we see in the eyes, we can imagine a certain picture that occurs in the central nervous system, or accordingly, the peripheral nervous system. So these things are very closely related, and accordingly, there are a lot of pathological conditions. So, of course, we will go through everything, but we will focus on the most common ones. For example, Horner's syndrome, or it is also called the parasympathetic syndrome, is associated with damage to the sympathetic part of the nervous system, particularly the cervical sympathetic ganglia, which, as we know, largely innervate many structures and muscle elements inside the eye. And such damage can be primary elements inside the eye. And such damage can be primary, they can be secondary in relation to some pathological process, starting from oncology, ending with injuries or with a pathological process, and so on. As we know the path from the cervical ganglion to the eye consists of two main neurons. Damage to the first neuron is the section of the pathway between the hypothalamus and the cervical spinal center. It can be caused, for example, by a cervical spinal cord injury or by the blockage of the posterior inferior cerebellar artery. Damage to the second neuron is the section from the spinal center to the upper cervical ganglion. In ganglionic damage, so-called this, for example, is compression of the sympathetic pathway, a tumor, the apex of the lung. And there is also a third neuron that goes from the section of the upper sympathetic cervical ganglion, which dilates the pupil. And accordingly, this is just ganglionic damage. At the level of the internal carotid artery, for example, or a tumor of the cavernous sinus, it can also lead to the development of Horner's syndrome. Accordingly, in each of these cases, the degree of manifestation of Horner's symptoms varies. I won't go into detail here. Well, the first thing we see in Horner's syndrome is ptosis, the drooping of the upper eyelid, narrowing of the palpebral fissure due to Müller's muscle paralysis. Miosis is the constriction of the pupil with the parasympathetic dilator. Well, it's precisely that part of Müller's muscle which is in the dilator where parasympathetic innervation starts to dominate. The sympathetic innervation dilates the pupil while the parasympathetic innervation constricts it, as we know, and accordingly the influence of parasympathetic innervation leads to the constriction of the pupil, and accordingly the influence of parasympathetic innervation leads to constriction. Pupil in ophthalmos, the sinking of the eyeball is caused by paralysis of the orbital muscle, causing hyperemia of the conjunctiva and redness of facial blood vessels from loss of sympathetic control. Hyperemia of the conjunctiva, redness of the blood vessels on the corresponding side of the face due to the loss of sympathetic vasoconstrictor reactions. There is less vasoconstriction, leading to increased blood filling of the vessels due to their dilation, which causes redness of the eyes. Depigmentation of the iris. This happens in the case of congenital Horner's syndrome. As the iris develops, the iris begins to lose pigment, but this only happens if Horner's syndrome develops almost immediately after birth or has a congenital nature. Here we show different variation of the manifestations of Horner's syndrome, as you can see. Here's the lower image. It shows an ophthalmos, upper miosis, and hyperemia of the conjunctiva. Next, the causes of Horner's syndrome. They are also written on the slide. All these causes can lead to Horner's syndrome. And here, I want to talk about pathological formations in the brain, which can also be causes. This is a very interesting phenomenon. Aneurysms of all kinds, inflammatory processes. We can't help but mention the quite vivid eye symptoms, like the loss of visual fields. Here, we need to note this down. We can have heteronymous bitemporal hemianopsia. We can have binasal hemianopsia, which means accordingly seeing with Horner's syndrome, and homonymous hemianopsia. These are the variations of the corresponding changes in the visual fields. Corresponding changes in the visual fields. One of the most common hereditary neurological diseases, the other condition is neurofibromatosis or Recklinghausen's disease. It is characterized by pronounced polymorphism of the boundary manifestations, progressive course and frequent involvement of various organs and systems leading to severe complications. This disease often leads to a fatal outcome. There are 2 periods of sharp increase in the activity of the pathological process. The first period is from 5 to 10 years, and the second is from 35 to 50 years. In this case, the second period of activity occurs in the overwhelming majority of cases, 75%, caused by the malignization of tumor formations. The specific sequence of symptom manifestation of neurofibromatosis type 1, depending on the patient's age, which makes it difficult to diagnose in young children. So neurofibromatosis in children during the first years of life can be present from birth only in the form of some signs of the disease. More often, these are large pigmented spots, cellular dysplasias, Lisch's nodules, so-called on the iris, Wilson's disease, another syndrome, hepatocerebral dystrophy, hepatolenticular degeneration, it's all the same disease, congenital copper metabolism disorders that lead to severe damage to the central nervous system and internal organs. They are diagnosed in 5–10% of patients with cirrhosis of the liver, in preschool and school-age children. On this slide, we show you different changes and Wilson's disease, accumulation of copper in various organs and tissues. It occurs, but most often the liver and the brain are affected. The diagnosis is comprehensive. As a rule, ophthalmological examinations, biochemical tests of urine and blood, as well as MRI of the brain are prescribed. Abdominal cavity in the extrapyramidal cortiform. Epidemic seizures and pyramidal insufficiency syndrome are possible, often during the ophthalmological examination. Initially, we observe a specific symptom, the so-called Kayser-Fleischer rings, which help confirm the diagnosis and start timely treatment. Also, as an example, during a regular ophthalmological examination, nonspecific changes in the optic nerve can be detected, which may not even present a clinical picture, but could indicate the presence of neurological issues. At an early stage, in turn, when such changes are detected, the patient starts receiving treatment as early as possible. At the neurologist, of course, we use instrumental studies, which we will discuss next, to verify the diagnosis and develop a treatment strategy, highly informative. The method involves examining the retina using optical coherence tomography. Based on this study, the condition of the optic nerve, the macular area, as well as the thickness of various layers of the retina. By combining with other diagnostic methods, we can develop a strategy for further treatment and make predictions about the possibility of improving visual acuity for a specific patient. This slide shows the optical coherence tomography of the retina. We see that the retina is pathologically thinned. All layers are evenly thinned, except for the foveal layer, that is the central zone, as well as the underdevelopment of the macular area, meaning the macula is not formed, the so-called macular aplasia. In turn, we cannot diagnose pronounced partial atrophy of the optic nerve because we do not observe pronounced atrophy of the optic nerve. Or on the contrary, we can confidently diagnose partial atrophy or complete atrophy of the optic nerve in such patient with such a picture of the retina. Here, I want to show the method I proposed for studying visual acuity using a linear pattern with various orientations and angular sizes, which allows for the detection of meridional amblyopia and differentiating it from organic neurological pathology. In patients with astigmatism, it's important to note this and assess its degree. This meridional amblyopia. To develop a pathogenetically justified treatment strategy, meridional amblyopia is a complication of uncorrected astigmatism of more than 1.5 diopters at the right moment. There is selective deprivation, as if selective deprivation of visual stimuli that have a certain spatial orientation. For example, if you have, let's say, one focus in the hypermetropic part and the other focus is closer to the emmetropic part, it turns out that those objects that have a spatial orientation that matches that focus, which is closer to the emmetropic part, are perceived significantly better. That is, the vision of such objects, if we consider such objects, will be better than the objects. For example, those that have a spatial orientation more are located far away. The focus is located along the meridian, respectively, to this one that is further away, are located along the meridian, respectively, to this one that is further away. There is a selective effect in the same eye. We have it's like part of this eye is amblyopic and part is not amblyopic. And this is related to the unique innervation, the stimulation of these different receptive areas on the retina. And this is related to the peculiarities of the actual innervation of the stimulation of these different receptive areas on the retina. Low or degree correction works. It's often enough to have the correct correction for low degrees in order to treat this for you. But specific treatment is also necessary, which will allow for selective stimulation to cure. Receptive stimulation. Receptive areas of the amblyopic. This meridian and what we did, the visually evoked potentials that we are using here to identify this very meridional amblyopia. It is done using a special technique with the application of appropriate stimuli with a rectangular light profile rather than checkerboard patterns, as is usually the case, and definitely not flashes. And they give us the opportunity to objectively test visual acuity without the response of different meridian patents. Well, here it is. That's what I was talking about. As you can see, different receptive zones, they are different. Focus the image differently. Well, in this case, hyperopia is located further away. We patented both the method and the treatment approach. And in our country and in the world and in the United States and everywhere. Let's move on to the next condition, nystagmus. As for conditions like nystagmus, such as it is necessary to note that they are at the intersection of epilogy, neurology, and diseases. Optical nystagmus, or what is also called fixation nystagmus, occurs as a result of poor vision quality. And having specifically poor quality from early childhood, more precisely from the moment of birth. Optokinetic nystagmus indicates a dysfunction of the visual analyzer, particularly the photoreceptors in the retina. Well, and vestibular nystagmus, which is caused by irritation of the vestibular analyzer. In various neurological pathologies, the most common form of nystagmus is neurological nystagmus. 6.8 cases per 10,000 population. Followed by nystagmus associated with early visual deprivation, which is related to, or ocular nystagmus, so-called fixation nystagmus. For example, nystagmus caused by cataracts is 4.9 cases per 10,000 population, and nystagmus is associated with a disease, thus 7.6, a whole 6 out of 10 cases per 10,000 population is the type of nystagmus that is treated by eye doctors. So that's the statistics. Acquired nystagmus develops in the shadow of life and may be a consequence of brain disease, multiple sclerosis, dementing diseases of all kinds, hydrocephalus, encephalitis, circulatory disorders, and they can be listed. Diseases of the vestibular apparatus can also be acquired nystagmus. This is inflammation of the middle ear, Meniere's disease, vestibular neuritis, labyrinthine disorders, and injuries to the eyeballs can also lead to the development of acquired nystagmus. Now let's talk about fixation eye nystagmus of acquired nystagmus. Now let's talk about fixation eye nystagmus. This happens in ocular albinism of all kinds of genetic diseases. Here we are showing you a picture of the fundus. In albinism, they are visible, or I know the direction. They are transparent due to the lack of pigment, and the choroidal vessels shine through. Here they are all twisted like this. You see, this is such a picture of ocular albinism. Here it should be noted that not all albinism is externally visible. There is hidden albinism. The fundus has this kind of picture. It's always important to be attentive. The hair is not white, the eyelashes are not white, but the fundus has this kind of picture. This kind of situation can also happen, so it's always important to pay very close attention to this moment. Identifying hidden circumstantial albinism in the presence of nystagmus is very important. Next, let's move on to the main and most significant diagnostic method regarding nystagmus. Initially, the assessment of eye movement appeared among neurologists. Neurologists were the first to start evaluating. They use this method to determine the type and level of CNS damage when they study eye movement in nystagmus, and, for example, in ataxia, patients with dizziness, and so on. As a rule, patients are initially another method for studying eye movement. As a rule, patients are initially. I'm going to ask you to pay close attention to all the proposed methods because some of them, as you can see, are quite cumbersome and complex. Well, for example, you can't do them right away for children. Well, the method that is currently in front of you is not very accurate, but nevertheless, all these methods were used in one way or another in their time. I don't give not giving even a partial picture. Nevertheless, they helped a lot when assessing the location. MRI is a very important research method, and CT scans will show us the presence or absence of any processes behind the eyes. Accordingly, with apples in the orbit, well, here, usually if partial atrophy of the optic nerve was previously recorded on OCT, then on MRI we will find it one way or another, find it thinning of the optic nerve or its sheaths, which further confirms the diagnosis. If the thickness of the nerves is within the population norm, then this gives an understanding of what in the future for this patient we can plan courses of conservative treatment aimed at improving visual acuity. Here we have it. The possibilities of making predictions arises from the proper use of modern diagnostic capabilities. In addition to the ophthalmological structures, when assessing the brain, we can evaluate other areas and identify any accompanying pathology. Well, if it exists, starting from septo-optic dysplasia to tumors and hematomas that can provoke nystagmus in adulthood, this diagnosis allows for accurate verification of the diagnosis and appropriate selection, correct treatment. Besides the ophthalmological field, nystagmus as a symptom is very important in the practice of ENT doctors and neurologists. In the specialties, there are specific developments and practices used in the differential diagnosis of systemic dizziness and diseases of the inner ear, differential diagnosis of central and peripheral nystagmus. Well, nystagmus as a symptom in various diseases, systems. Well, here it is from studying nystagmus helps in the differential diagnosis of central and peripheral nystagmus, which is useful for the nerves, or in the jaw vestibulopathy. For differential diagnosis, proper research is necessary. Here you see one of the methods that is also used. Here's another method. The corresponding protocol that you see on the computer. Well, this is one of the methods, the so-called Dix-Hallpike test for diagnosing benign paroxysmal positional vertigo. Well, this is probably more interesting for neurologists and ENT doctors. You can take a look at the stages of this test. And now I want to present to you the best that we have today. Actually, it's the study of nystagmus. This is our both development with our Spanish colleagues. We did this together, a magnificent device, the optical oculograph. It's called Gaze Lab. It's compact, easy for patients to carry, and provides excellent capabilities for studying all parameters. Nystagma, It measures the frequency, amplitude, and speed of eye movement, as well as the fixation point. At certain points, nystagmus is blocked. These are the blocking points that we can find, and a lot of other changes in these parameters, in various directions of gaze. And all of this is evaluated by the corresponding protocol on the computer. We have a complete picture of nystagmus. Accordingly, this is very important for us in surgery, nystagmus, in eye surgery for nystagmus. We successfully operate on nystagmus. We really block it. This kind of protocol is very important. So that's the development we created with our Spanish colleagues. Today, it is conquering the world. It is considered the best way to assess the characteristics of nystagmus. As of today, here we can assess with both eyes open, with one eye open, the left or the right, in various directions of gaze. As I mentioned, this is a very interesting and very multi-purpose way of investigation. And I must say we have it in Bahrain, probably the only clinic that has the ability to assess eye movement in nystagmus today in the Kingdom of Bahrain. Well, I think that not only in the Kingdom of Bahrain, but throughout the Gulf. Dear friends, everything I told you today is not even a small part of what usually happens with various nerve pathologies related to the eyes. And these are very interconnected topics. Here I must say that in such conditions, it's very important, such intensive work, definitely joint, and neurologists, sometimes neurosurgeons, to help patients. The same goes for identifying and making the correct diagnosis. Sometimes we ophthalmologists are the first to detect some changes in the eyes, which in turn turn out to be the first symptoms, complex neurological diseases or complex autoimmune diseases. So, in general, close contact between neurologists, immunologists, and ophthalmologists, as well as, of course, endocrinologists, and therapists in various diseases, for example, hypertension. This is the key diseases, for example. Hypertension. This is a deposit, successful assistance to our patients. Thank you for your attention.